So there's a huge distinction between extubating somebody in the operating room and extubating somebody in the ICU.
Right.
Obviously, somebody comes into the operating room, they come in, they say, hey, how you doing? You put them to sleep, and then this is how you extubate them at the end of the case. Are you awake? Great. You pulled the tube. So that's not at all in the way we think about extubating somebody in the ICU. So there's a number of different things that go into thinking about when we extubate somebody. You start with what is their FiO2 and what's their PEEP. So by definition, we will not extubate somebody unless they're in chronic significant home oxygen. We'll not extubate somebody at an FiO2 of more than 50%. Okay. So you start at FiO2 of 50%, sending with PEEP, you're not going to extubate somebody in a PEEP of more than 8. So your entry point into considering a spontaneous breathing trial is adequate oxygenation, adequate PEEP. Once you hit that basal level, then you are concerned about 3 or 4 different things. You're concerned about, are they strong enough? Do they have the appropriate mental status? Do they have the appropriate pulmonary mechanics? And then finally, potentially, especially in a surgical ICU type environment, do they have cuff leak? So taking those one by one, how do you assess if they are strong enough?
There's a few things you could do. You can have them lift their head up off the bed, or ask them to lift their head up off the bed. That sort of does 2 things. They can follow commands and they're strong enough. You can check their cough, ask them to cough.
Mm-hmm.
Those are the 2 ways that I would know.
Yeah, I usually go by the first, which is because the cough is a more subjective way. I usually ask them to lift their head off the bed. And how long do you want them to lift their head off of the bed for?
Long enough for them to know that I don't know the answer to this question.
Usually 5 seconds.
Okay.
And you'll get a lot of people who won't want to do that, right? Especially in the surgical ICU, they have an incision, it hurts. And so going like that is not a particularly big deal, but if you're going like that and you've got an abdominal incision, the appropriate response is to grab and stop. And so then somebody's going to shake their head no. What do you do if you want to really somebody to do it, and they grab and they refuse to do it? What should be your response to that?
I know it hurts, but you got to do it or I'm going to keep the tube in.
Exactly right. If you can pull your head off the bed for 5 seconds, I'll pull the tube. If you can't, I won't. And magically, everybody discovers the pain tolerance for 5 seconds to pull their head up off the bed. So you have to make sure they're strong enough. If they're not strong enough, what happens? So if you extubate them and they can pull their head off the bed for only 1 second, they're not strong enough. What's going to happen?
We either live to fight another day, or they will get more agitated and the nurse will say they're in pain and we'll knock them back again. So I feel like there's a... Very
poorly worded question. If you extubate them despite them not being strong enough, what happens?
We'll get re-intubated.
How quickly?
I don't know.
Not that quickly. So this is not the same as stridor. So if you extubate somebody in their stridorus, their vocal cords go like this, close, and they get extubated. So if somebody's not weak, if somebody's not strong enough to protect their airway, what happens? They can breathe, assuming they pass the spontaneous breathing trial. We'll get to that in a bit. But they're strong enough to do it, but they don't have an appropriate cough effort. They're really weak. And so what's going to happen? And nothing is coming up. And so they're developing more and more atelectasis. They're developing mucus plugs. And eventually they're going to get weaker and weaker and get extubated. So in somebody who you're extubating, who you're concerned about their strength, you say, well, I'm not sure how they're going to do. They're not going to fail immediately, which also means that if you extubate them, they're not off your radar screen in half an hour. You have to continuously watch them. And again, we're not a neuro ICU, but think about somebody with ALS, with Lou Gehrig's syndrome. If you extubate them, they don't fail on their own. Why do they fail? They fail because they don't have the strength to do anything. They can't cough anything up. So the first thing you do, once you have their adequate FiO2 and PEEP, is check their strength. Let's say they've got adequate strength. The next thing you want to do is check to see if they're following commands. And yes, to some degree, saying pick your head up off the bed is following commands, but it's not the best command in the world. How do you typically ask somebody to follow commands?
Well, you typically what I've seen, and you can tell me.
It's not a right answer. There's more than one way to do it. I know what I do, but there's more than one right answer.
Exactly. So squeeze my hand, which you can talk about. Give me a thumbs up. Give me an okay sign. Those are kind of the commands. Wiggle your toes.
Yeah, so I partially like some of those, and I strongly dislike one of them. And I don't love any of them. The one that you have, read my mind, which is the one that I strongly do not like.
Strongly do not like squeeze my hand.
Exactly right. because anybody who's watching this video who has a newborn baby, the length of time it takes you to squeeze your parent's hand is being born, because it is a grasp reflex. And so we have all types of people with persistent vegetative states whose family believes, because they have a grasp reflex, that they are following commands. And so that tells you absolutely nothing.
That's not even like the best reflex. The best reflex is like the Moro reflex.
Right. And so what you want to do is get something that is complex and honestly involves laterality. And so I typically do the show me 2 fingers, not 1 finger for obvious reasons. Show me 2 fingers on your left hand, or wiggle the toes on your right foot. And that, again, for those who have children watching this, you have any idea, not that you should have any idea, but you have any idea of what age a child understands the concept of left versus right?
I still have trouble. So.
Yeah, right. So, but you'll see people with relatively young children say, show me your left hand, know the other left. Because it's actually a complex command. Because at the age of 2 or 3, when you can do a lot of simple things, you actually don't know your left from right. And so by the time you can understand the concept, I know my left from my right, I understand the concept of these are 2 fingers, or I'm wiggling the toes of my right foot, that's actually following complex commands. So that is very helpful towards extubating somebody. It's not mandatory if they have a brain injury, because not everybody with a brain injury walks around intubated forever. But it is certainly something that if you think it's reversible, you want to know that they can follow commands.
So the complexity is sort of lateralizing, maybe, and then doing more of a complex command than simply just one, like a single.
Well, a single finger is fine. The problem is, in many places you ask for a single finger, you will get that single finger, and it will be the middle one. So there's nothing wrong with saying, show me your thumb, or show me 2 fingers. You can say, show me 1 finger. It's just, sometimes it's funny. A lot of times people will give you a humorous response to that. But yeah, if you ask any kind of a laterality, and something that you're confident they're doing. The reason I say 2 fingers as opposed to, show me, whatever, it's too easy to do something like that, and you're like, say, did they just squeeze? Did they just do,
Right.
You say, show me 2 fingers. This is pretty, say, this, whatever else. They can do the Spock thing, but whatever. They're going to give you 2 fingers you can actually see.
Okay.
Then the next thing is to see their work of breathing. So how do we assess their work of breathing?
So typically we use the rapid shallow breathing index.
Exactly right. So for those out there in viewer land, how do you calculate the rapid shallow breathing index?
It's the number of breaths they're taking over time. Yes, I believe. Time over, I can't remember the exact.
Well, half of that's right. So it's the respiratory rate divided by the tidal volume.
Tidal volume, I'm sorry.
And it's the tidal volume with a point in front of it. So it's based upon liters. So 1 liter is 1, 500 cc's is 0.5. So I'm going to take you through, so we'll start with what is a failing number. There actually is no passing number. People get this wrong. They say there's a passing number. There's actually a number that predicts failure. There's not a number that predicts success. So let's talk about, do you know what the number that predicts failure is?
I think it's over 60.
So
believe.
60 is a soft fail, soft pass. The failing number is 105.
Okay.
So if you're greater than 105, you're going to fail.
105 is definitely
105 is predictive of failure. 60 to 105 is the gray zone. Less than 60, it doesn't. Again, there's no predictor of success, but the chance of failure is relatively low. Because it is a random number, and you're trying to remember the numbers, I'm going to try to put this into context of what actually counts as normal or not. And because again, this is very different from the operating room when we're extubating somebody. So as we're sitting here, if I'm not asking you questions that you weren't expecting to get asked, you just are expecting a free look at my office today. What's your respiratory rate?
At the most 12.
Okay, and what's your tidal volume?
About 300.
I'm going to make that simple for the sake of math, and I'm going to make it 500, even though it's not. You're right. So if your respiratory rate's 12 and your tidal volume is 500, what's your RSBI?
I can't do this math in my head. I know I'm Indian.
It is 12. It is 12 divided by 0.5, also known as 24.
I'm pretty sure Priya was a Kumon instructor. In
I
a
was.
previous
I
life.
actually did teach Kumon.
Kids, don't send your kids to Kumon.
Okay.
Or to Harvard, where the band would appear to be relatively inferior. So 12
I
divided
majored in
by
politics.
12 divided by 0.5 is 24. So again, our failing number is 105, and our soft pass, soft fail number is 60. So just for baseline, we're 24. So if you take those, I'm going to keep on simple math. We're going to take our respiratory rate and go from 12 to 20. Our tidal volume's 0.5. What's your RSBI?
It's a 40.
40. Passing number. Okay? I'm now going to take your respiratory rate of 20 and giving you a tidal volume of 333. What's your RSBI?
Um,
20 divided by 0.3. 60.
60.
I'm not trying to
I
stress
know,
you out
it's
here.
listen.
We had the 21 Pilot song going in the background.
I promise I did go to the universities I could to have gone to.
So the bottom line is the sort of 60 is a respiratory rate of 20 and the tidal volume of 333, which we would never consider to be normal. Let's take that even more. Let's take our respiratory rate and make it 30 and our tidal volume to be 333. Our RSBI is 90 then.
Yeah.
So that is still not a fail. So when you're doing your RSBI, to get to the number of 105, if you're markedly tachypnic, respiratory rate of 30, and tidal volume of 300 or so, you're still actually passing.
Mm-hmm.
And people don't talk about failing, they'll call it passing even though it's really failing. And so you really, it's not just enough to say, did they pass or fail their SBT? So you put them on a spontaneous breathing trial. It's not enough to simply say, did they pass or did they fail? You actually want to know the number. By the way, when we put them on a spontaneous breathing trial, you put them on a rate of 0, and you want to put them on enough pressure support to overcome the resistance of the tube. That's different at every hospital. Mm-hmm. So if you're at Grady, it's going to be different from Midtown. It's going to be different from it is at EUH because we have different vents in each place. And so if you're at Grady, you're going to put somebody in a pressure support of 5.
That's right.
And if you're at EUH, you're going to put somebody in a pressure support of 0 with tube compensation. It's exactly the same. They're different vents, so they appear to be different. So you actually have to know at least that much of a what counts is just enough to overcome the resistance of the tube. Because if you put them on truly a PSV of 0 with no tube compensation or PSV of 0 at Grady, they're breathing through a straw and they're more likely to fail. That's not fair. You basically want to give them enough pressure to overcome the resistance of the tube. So you do that for a minimum of 30 minutes
Mm-hmm.
and a maximum of 2 hours. You don't want to go beyond 2 hours. It actually makes them tired out. You don't want to go for 10 minutes because that doesn't necessarily give you enough time to fail. Because again, you might start out, let's say you start out breathing, if you start out breathing 12 times a minute, your tidal volume is 500, normal, you're going to pass.
Mm-hmm.
But let's say you start breathing 20 times a minute. And yeah, they're a little bit tachypnic, but the tidal volume is okay. And then you go another 10 minutes and then they're a little bit more tachypnic, or the tidal volumes go down. You want to go at least 30 minutes to actually really know what they're doing.
Okay.
And then you find out, did they pass their SBT or not, by finding out the actual RSBI. And again, less than 60, you're fine. 60 to 105, you need to look at them. Greater than 105, they fail.
So where did the number 105 even come from?
Somebody named Marty Tobin with a lot of time in his hands / a really good researcher actually looked.
Mm-hmm.
So they actually, you can go back and see, we did this analysis, we saw who passed and who failed.
So it's kind of an inflection point.
It is an
beyond
inflection
the-
point. Again, it's an inflection point of a prediction of failure. To some degree, for surgery, it's like the boards, at least it used to be. On the in-service, if you were below the 30th percentile in the in-service, you had a significantly higher chance of failing your oral boards. But whether you got 50th percentile or 90th percentile, it was no difference in terms of your pass rate. But below a certain level, you were significantly more likely to fail. And so when they actually went back at patient data, they went back and looked and said people greater than 105 are predicted to fail.
Okay.
And people end up calling that a pass, but it's important to understand that it's actually not a pass. It is a absence of prediction of failure. Because if it's a pass, then 25 is the same as 90. And they're not, because one is 3 times as tachypnic as the other one.
Right.
At the end of your RSBI, what's supposed to happen then is you look at the patient and make sure that how would you fail during an RSBI? You fail during an RSBI by becoming hemodynamically. So either your RSBI changes or you become hemodynamically unstable. So your heart rate goes up to 160.
Mm-hmm.
That's fail. Your blood pressure goes up to 200. That's a fail. Or you don't ventilate. Those are pretty easy to see. What's not necessarily as easy to see is somebody who's not ventilating. And so you look at their end-tidal CO2. They're supposed to be a certain place where it starts. You know what their gradient is, which gives you some idea of what their PCO2 is. You look up on their monitor, and their end-tidal CO2 is 42, say. If you look up at the end of their 30 minutes, if their end-tidal CO2 is 55 right now, that means their PCO2 has gone up by 17.
Mm-hmm.
And that person, when you take out the tube, is going to fail. And so you do all this, and at the end of 30 minutes, you get a number. So you know now the person is strong enough, they can follow commands, they're an adequate FiO2 and PEEP, their RSBI is an adequate number, they're hemodynamically stable, their end tidal didn't change. All is good, and now you're ready to pull the tube, except for one possibility. And that one possibility is you have to think about how much fluid they have on board. So again, when somebody gets intubated, extubated in the operating room, it's because the case is a reasonable length of time. If you're doing a case and it's 16 hours, is anesthesia going to extubate them at the end of the case?
Probably not.
Even though they can reverse them and they can extubate them at the end of the case, they're still not going to. because of concerns about fluid shifts. Well, it's pretty easy to look at fluid shifts in terms of the pulmonary mechanics. Again, we've just done the RSBI that tells you, are they breathing okay? Yeah, they're breathing okay. They're awake, they're strong enough, and everything else. So what are you concerned about? I'm going to use the analogy of the burn that you see in the ED at Grady that all of you guys are watching this thing. And so if you have somebody in the ED who has an inhalation injury and they are very tugging like this, but they're sounding 100%, what are you going to do?
Probably intubate.
You're going to intubate them emergently, right?
Yeah.
Because you're concerned that they've got vocal cord edema and that their vocal cords, which normally look like this, are now like this.
Mhm.
And they're this close to just shutting off. And even if they're saturating 100%, if they shut off, what do you have? You have 1 minute to crank them or they're going to die, right? And so somebody with laryngeal edema, you're going to vocal cord edema, you're going to intubate as an emergency. Now, think about somebody who gets a huge amount of volume, either because they got a big volume resuscitation in the operating room or because they're septic and they got a big volume resuscitation in the emergency department and then we've given the equivalent and they're 20 liters up. How will that manifest itself to the family?
You'll see it all over their legs. They'll look like the Michelin Man.
Right.
and-
So the family will complain to you, oh my God, they're so swollen. Why do they look so swollen? I've never seen them look so sick. Are you concerned about that?
No.
You're concerned about it solely and only from a humanitarian standpoint. Like you don't want the
Yeah, I mean,
patient to be
yes,
uncomfortable.
I'm
Right.
concerned.
You don't want the patient to be uncomfortable and you don't want the family to be uncomfortable and you know they're scared. But you also know that fluid in the extravascular space is not going to harm them as long as it's not hurting their pulmonary mechanics. So you've done your RSBI. And you've done your RSBI, and your RSBI is, say, 50. It's not normal, right? It's twice normal, but that's okay. That's fine. And so you might say, okay, everything is cool, but they still look markedly edematous on their physical exam. What I do then, and this is not as evidence-based as anything else I've said, because this is fairly controversial, so I will acknowledge that. So somebody could go to the literature and say, well, it doesn't really make much of a difference. I then do a cuff leak. There's two different ways to do a cuff leak. One is to have respiratory, basically just take out the deflate the cuff and look to see how the tidal volume changes on the ventilator.
Mm-hmm.
What I do is I silence the alarm on the vent. You disconnect them from the ventilator, put your finger over the edge of the tube and then deflate the cuff and tell them to breathe. And one of two things is going to happen. They're going to go like this, or they're going to go like this. The first one is okay because it means they're able to breathe around the cuff. The second one is not okay because they can't breathe around the cuff. So is there any chance, as long as the tube stays in place, that they're going to die because the airway is going to close off? There's no chance because the tube is stenting the vocal cords open, right? But again, go back to that patient you had in the ED at Grady who you're emergently intubating for. You're basically putting it in, you're getting it. Sometimes you can't even get a regular tube in. You have to get like a 5 or 6 in because they're otherwise going to die, right? And so now it stents it open and it will stay open at that size. What happens if you pull the tube? Vocal cords close. Immediate life-threatening situation. There's no burn here, but it's the same concept. You've given lots and lots and lots of fluid. The family sees it in the interstitium. The family sees it in swollen arms, swollen legs that look like the Michelin Man. Your concern is that when you pull the tube, the vocal cord is edematous and it's going to close off. So you do the cuff leak. If they pass it, you've now passed everything. Strong enough, awake enough, appropriate SAT, hemodynamics, appropriate RSBI, appropriate cuff leak, tube, garbage can. If they fail any of those, you live to fight another day and you figure out what's causing this. If they're not strong enough, you work on physical therapy. If they're not awake enough, you work on their psychoactive medicines or deal with the underlying cause. If they pass everything but fail the cuff leak, usually that means they have too much fluid on board.
Sure.
And then you go ahead and diurese them until you don't anymore. Until they pass the cuff leak, and then you pull the tube. And that is it.
Simple.
Simple.
Easy peasy. I don't even know what we talked about. It's so easy.